And it's my great pleasure to introduce the first speaker, who is Dr. Nicholas Opie. And Nicholas, you could tell by the way in which Alan Finkel engaged with him at dinner last night, has really got a story. They were in solid, deep conversation for 15 minutes, and it was clear the exchange was of mutual recognition. Alan knew all about your work already, and you folk, if you don't know about it, you're going to hear about it soon. I'm just going to introduce Nicholas briefly. He has a doctorate in 2012 in the area of the bionic eye, and he was awarded a $1.3 million grant in 2012 from DARPA to develop a minimally invasive brain interface with a machine interface. And this is expanded to a $5.5 million grant to establish and co-lead the vascular bionics laboratory within the Department of Medicine at the University of Melbourne. And there they have a team of more than 20 people, graduate and postgraduate, undergraduate, postgraduate, and he's leading the research team conducting preclinical safety and efficacy trials on a device capable of recording neural information within a blood vessel. And this may enable direct brain control from, for example, control of wheelchairs and exoskeletons and computers to people with paralysis as early as 2017. He's founding Chief Technology Officer of SmartStent, a company incorporated to translate endovascular biotechnology, bionic technology, into clinical application. And I think it's great that we can admire people with such entrepreneurial skills. And I long for the day when we take it for granted that everyone's doing that. Meanwhile, we applaud you, Nicholas, for what you've done. And I invite you to come and give your talk entitled Minimally Invasive Neural Interface.
Thank you. Well, thank you for having me here today. It's a real honour, and I'm very excited to discuss some of the work that we've been doing on minimally invasive neural interfaces, some exciting technology that's come out of Melbourne, in particular the Royal Melbourne Hospital, the University of Melbourne, the Florida Institute of Neuroscience and Mental Health, and of course our startup companies, SmartStent and Synchron. Before I go into too much detail on what a minimally invasive neural interface is, I want to try and paint the picture as to why we think this is important and how this can affect the future. And it's paralysis, really. The main reason that we're doing this is to help people with paralysis. There are many different ways that you can lose function of your limbs. This can be through stroke, like the lady in the top corner. You can have a spinal cord injury, which I'll speak a little bit more about later. And also, one of the reasons that DARPA was interested is there's a lot of people coming back from war with amputations, and obviously there's an increase in medical response times, and their body armour is getting better. So instead of dying in the wars, they're coming back, but they're having loss of limb. In Australia, there's about 60,000 people with paralysis of different types. In larger places like the States, there's around about 6 million. And in the next decade, McKinsey Global's predicted that the number of people that will be requiring what they've coined human robotic augmentation is expected to reach around 50 million. So there's a large number, and obviously we all hope that it doesn't get that high, but if it does, we have to think about what we're going to do about it and how we can work this out. I want to speak a little bit about spinal cord injury, mainly because this is something that can affect anyone, obviously including Superman. There's about 1.2 million people that have this condition in the States. Most of them are male, so obviously that's why this resonates more strongly with me. And they're also very young males when they receive these injuries, often through risk-taking behaviours, diving into a shallow pool to impress a girl, or driving too fast to impress their mates. Conditions like this, which render their limbs useless, and for them there is no cure and no treatment, and a lot of them are just living their lives out in nursing homes. So we want to do something about this, and we want to help a lot of these people and return to what they were beforehand. There's some excellent technology coming out. So this is an exoskeleton. This lady here had a skiing accident and severed her spinal cord and lost the use of her limbs. And as you can see, that with minimal training, she's now able to stand up and walk around using this exoskeleton. So there's some pretty amazing technology coming out. A couple of things I want to bring to your attention. Firstly, if you don't have upper body strength, or if you don't have arms at all, you're not going to be able to control this tech. And the second point I'd like to make is that the gentleman standing behind her, he's controlling the legs and when they move. Now, this is obviously fantastic, and it's great to see this solution available, but we need to do something better. And I think the way that this technology is going to go forward is if instead of needing someone else to control it, there's a way that we can access the brain directly and get the person to control their own exoskeleton or wheelchair. And so that comes to brain-machine interfaces. There's 3 main steps. First of all, you have to acquire the signal, so you get the information from your brain. Secondly, you need to decode them and work out what all those signals mean. And thirdly, you need to have some apparatus where the signals can control something. Now, we don't really mind what that is. If the patient needs a wheelchair, or if they want to control a computer or an exoskeleton or whatever it might be, we want to give them the opportunity to do so. So what we're really focusing on is how to get the signals and how to decode them and understand them and use them to control any of these different types of technology. The 3 main types of existing sensors that record brain activity, I'll go through briefly. Firstly, there's the non-invasive scalp electrodes. These are electrodes like shown in this image, although it's a bit of a laugh, this one, but there are lots of wires coming out. It's very difficult to put on, particularly if you're paralysed. I think it's going to be quite difficult. And more importantly, though, the signal that you get is attenuated by the skull, so the information from the brain just doesn't get through in a way that it would be required to control a highly dexterous robotic limb. Now, I'm not saying there's not a place for these, there is, but if you want to control something with a lot of degrees of freedom, then this technology is not where it needs to be right now. So moving on from non-invasive, you get more invasive electrode arrays. This is being done commonly, and you take the patient and you cut a hole in their skull and you remove the skull and you put electrodes directly onto the brain themselves. In this particular image I've got here, and apologies that I didn't warn you that this was coming up, this is done for epilepsy, and so to try and record and work out where the seizures are coming from. As with most surgical procedures, there's obviously a risk, and this is no different. There's about 26% chance that a serious complication is going to occur if you remove part of your brain, remove part of your skull to access the brain. And it's a bleeding infection and in worst case death. So we need to try and get a step past that as well. Invasive subdural electrodes and penetrating electrode arrays, they use a much smaller hole in the skull, so the surgical complication rate is a bit lower. They do still have that surgery, and the other issue is that these electrodes essentially a bed of nails, and you use a pneumatic inserter to fire them into the brain directly. It may sound quite crude, and it is, but these are working really well. The problem with these is they're not working really well for a really long time. They're working great to start with when the patient learns how to use them, but over time they start getting rejected and there's fibrous tissue growing over the electrodes, and the ability to continue using these is decreasing. But they are working well, even at this stage. And I want to show you a video of a gentleman here who has one of these penetrating microelectrode arrays implanted in his brain. He's paralysed, and yet he can still control this robotic arm and also the cursor on the screen. So we do know that if you access the brain, you can get information out, and you can use this information to control various devices such as computers and robotic limbs. So that's great. This technology is looking really good. The problem that was found was that over time they stopped working, and I'll show you a few things about that later. But there are different regions of the brain that we're trying to access, particularly for motor prosthetics, and this is the motor cortex here. You can see what we've shown as well, doing some MRI images, is that there are specific regions based on whether you're controlling a particular limb, ankle or knee, or whether you're controlling left part of your body or right part of your body. And so we can target which part of the brain we want to access depending on what the patient needs. I'm not going to go into brain signals too much. This is a complete lecture on its own, but I just want to get a very basic point across that when you see squiggles like this, which is we're recording from the brain, we can essentially split that up into what we'll call low frequency and what we'll call high frequency. Now, I don't want to go into any more detail than that. I want to keep it simple for the point of this talk, but that's just to give you an idea of how we are going to use this information. And the way it's done is if you have an electrode array in, if you follow this blue line here, that's the frequency and the power you're getting from some of these signals when you're in a resting state, so when you're not doing anything. And what they've found is when people are doing action, so in this example, when they're moving their hands or moving their arms, you get changes. You get a decrease in the low frequency bands and an increase in the high frequency bands. And the reason I bring this up is because this is a very basic way of giving you an indication of how we can record brain activity and how we know what we're trying to get, and then in the future how we can use it. So some great work's been done by Wang and his group. They have placed one of those large electrode arrays requiring a craniotomy onto the brain, and they've shown that when they move the hand or the elbow in this case, they are getting these changes. So the red bars here is where there's increased activity, and you can see when they're opening and closing their hand, they're getting bursts of activity. And they were able to show that there are, again, different locations responsible for different limbs, but also that they can extract this information from the brain and use it to control a device. They did also investigate putting electrode arrays inside the brain's folds, and they found that that was better than placing them on the surface. And why that's important will become apparent by the end of my talk. So this gives an overview of why we need to do something about it. This was a graph that was done by Jack Judy, one of the DARPA program managers who has extensive experience over invasive and non-invasive neural interfaces. He's been, spent a lot of time and effort trying to work out a way to get reliable signals from the brain and get them to control or use these arms. So the technology of the arms and the robotics, that's there. I mean, this is a Decker arm. It's one of the most sophisticated going around. 22 degrees of freedom, carbon fibre and titanium. It's fantastic. Arguably better than our own arms because it's not going to tire and fatigue. But the question is, how do you connect that up? And how do you connect it up for a long enough time that the patient can continue using it for at least their life? If you see the blue line here, this is the surface electrodes, the ones that are just stuck on the skull. And you can see that they're obviously stable, but you don't get enough signal to control something really meaningful. And on the flip side, in the red line, these are the invasive electrodes, and they work really well. And like I showed you, the patient can control a robotic arm or cursors on a screen. But over time, these fail, and they don't last beyond the years that's required by the patient. So that's the puzzle we have. It's a four-piece puzzle, quite simple. First of all, how can it be effective? What do we need to do to make an effective brain-machine interface? And the best way to do it is to plant electrodes under the skull. The second piece is how do we make the procedure safer? And so we need to do the procedure without open brain surgery. So we have to get under the skull, but without doing surgery to get there. Third piece, obviously, is how can we ensure that the electrodes last a long time? And the way we can do this is by not breaching the blood-brain barrier. We don't want to directly affect the brain itself. So under the skull, without opening the skull, but in touching the brain, but not touching the brain. And then obviously functional, and how can you get it functional? And so if you put all these together, you know that you need to be under the skull, but without breaking the skull, and near the brain, but not touching the brain, and near this specific part of the brain that you want to control the limbs that you have. So that's the puzzle we have. And before I give you the solution of our solution, here's a hint of what we did. We took 50 patients and we measured using contrast-enhanced fMRIs, and what you can see here is in the red, this is the motor cortex, the part of the brain that we're trying to access for control of limbs and lower legs. And what you might notice is over the top, that's the blood vessels, the cortical veins, and they fortuitously lie very close proximity to this part of the brain that we're trying to access. And you can get there without doing open brain surgery. So we've come up with an endovascular brain-machine interface. It's a technology that can be delivered to the brain through blood vessels, that doesn't require open brain surgery, that can be underneath the skull so we can still get the good signals. We're not going to disrupt the blood-brain barrier because, as you can see in the image on the right, there's a vessel that protects the brain from our electrodes and likewise protects the electrodes from the brain. And we can also put it near the motor cortex or wherever we really want. And so this is our idea, and I'd like to take the next slide to introduce someone else to get them to explain what we're trying to do a little bit better than I can.
Hi everyone, this is President Barack Obama. The US and Australia are funding research into a device that could someday allow people to control their prosthetics with their minds and without invasive brain surgery. When implanted into a blood vessel, this network of tiny electrodes can record your brain signals, technology that has the potential to transform the lives of our wounded warriors and others with disabilities. It sounds like something from the future, but it's just another example of how investing in research can move us all forward.
So I like playing that little plug, but I thought he described what we're trying to do quite well and had some nice graphics along with it. So
Hi.
Let's just try and click to the next one. So to step through it with you of how we're going to achieve this, we want to have an option for people with paralysis. We're not saying that they need to have it, but we want to give them an alternative. And the first thing that we will do is we'll bring the patients in and we'll do an MRI to make sure that we know where the parts of the brain are that we want to access and where these little hotspots are that they can control. Then using a process or a procedure called angiography, we will access the brain and access the blood vessels. This is a procedure that's regularly performed to either remove clots in the brain or for anyone who needs to have cardiac stenting done. It's a day procedure, which means the patient can come in, get the procedure, and then leave on the same day. Reduces hospital costs and obviously the risk to the patient themselves. To access the blood vessels and to implant the device, all that's required is a tiny little incision on the neck. We don't have to do any major surgery, and the wound is so small that it will disappear after implantation. So you access through the neck, you essentially feed the electrode array up to the part of the brain that we're interested in, and then when we're there we will deploy self-expanding electrode array into the vessel near the motor cortex. And here's another video, not as shameless as the last one, but just an image of where the device is going to be implanted in the brain. And it's obviously one of the branching vessels. We'll access there through a telescopic catheter system and then deploy the electrode array, which self-expands to compress against the sides of the vessel wall. Now, this is technology that we have been developing, obviously with these partners in over the last number of years. And how it will work is the patient will think about moving their legs, for example, and then we will be able to record this activity, record those little squiggles that I showed you earlier. This information will then be transmitted from the electrode array into either an exoskeleton, a prosthetic limb, a computer, whatever the patient wants. Light switches, whatever the end result is really up to them and what they need, but we're just trying to get the information out and understand how we can use it. So that's all good. I've shown you a lot of images and a lot of stories about how this might work, but have we actually been able to do it? Like, what stage are we at? Is this even possible? The first thing we had to ask is, how do we get to this region, and how can we get there in a preclinical model that hasn't been used for angiography before? And so we developed a telescopic catheter system, a way to implant devices through the blood vessel, and you can see in the middle image a side view of one of our preclinical trials where there's the vascular network has been lit up. We inject contrast and we take an X-ray and we can see all where the vessels are. And similarly, if you look from the top down, that's the far right image, you can see where all these vessels are, and we know that we need to access around about here. So once we were there, we obviously did a lot of mapping and stimulation, try and work out what the region was that we need, and we're quite lucky. The motor cortex in this model is aligned directly with the superior sagittal sinus, this big vessel coming down the midline, so we can access and just implant the device straight forward. One of the other things that is important about this is that the vessel size in this model is almost identical to the vessel size in humans. So there's a direct comparison between what we're doing here and how we can translate it directly into a human population. So the device itself, we've called it a stentrode. It's a self-expanding electrode array. You can see in the image that we deliver it through a less than 1 millimeter catheter through to the area of interest, and when we're there, we can remove the catheter and the device just self-expands and presses the electrodes against the vessel wall. Now, this is important. Obviously, it's very hard to get a 4mm device if we need that all the way through, so being able to have this self-expansion is very important. But also, by using the stent technology, we can ensure that the inside of the stent and the inside of the vessel doesn't have anything in it. It expands and all the electrodes are on the vessel wall around the outside, and blood can still flow through the middle, so we're not causing any issues there. And here's a couple of X-ray angiographies of us putting the device in. It's a 2-hour procedure, and you can see in this yellow, this is where the device is located. So I'm an engineer. I have no medical training in this procedure. I do this regularly. It takes me about 2 hours. It's easy. And if I can do it, then someone who has trained for years to make this their profession can do it in an animal, being a human, with much larger vessels. They'll love it. It's a very easy procedure, and it's something that has very minimal complications compared to all the existing technologies. So we're very excited about that, and I do enjoy doing some surgery every now and then. But does it work? The first thing we wanted to know was, can we record neural signals? And I'm going to take a very broad aspect of this. And what we did was we implanted some of these devices, and on the left here you can see where the anesthesia was very high, and we're getting a particular signal up here. Again, I'm not going to go into too many details about this. And then obviously as the anesthesia wears off, the brain waves change and we're recording different signals. So from this work we were able to show that we can record neural signals, whatever they might be. And another point of interest was that after 1 month, the ability to record got a lot better than it did over the initial period of time, which is counterintuitive and almost opposite these other penetrating arrays, which over time get worse. It seems that ours is getting better. So we can record signals, but can we record localized signals? One of the issues that I had to start with was, if we're going to put something in a blood vessel and all these electrodes, blood's conductive, are they all going to measure the same thing? How are you going to be able to get different spots? And it turns out that, again, after, here's shown just for 3 weeks, the signal strength is getting better, and we can get individual and localized signals from each of the electrodes that we're putting in. So they're not all shorting together. We are getting discrete populations of neural activity. And here's an image, obviously, of one of our devices. The yellow dots are where the electrodes are. Bit of a graphical representation. You can see here these signals are changing, and each one is different to the others. So the next thing we want to do is, now we know that we can show localized movement, we can record signals. Can we record meaningful signals? In the animal model we chose, this is obviously difficult. They don't have hands, so there's a lot of things that we can't do with them, but we were able to get them to perform a forced choice task where there would be one button on either side. One of the lights would come on. It would have to choose which one based on whether the light was on or off, touch the button and get a feed reward. And what we found is very similar to some of the human work, that when the animal was doing an intentional movement, when it was thinking about doing things, we would get this big spike here of high frequency activity, which is correlated with intent and intentional movement. So we believe that we can record these neural signals that are directly related to intentional movement. Obviously, we wanted to compare what we're getting out from existing devices. If our device isn't comparable to them, then you need to go with the technology that's going to give the patient the best alternative. And we were very excited when we got this data out. So we implanted our electrode array, then performed a craniotomy and implanted some of the invasive arrays, and we measured the power and the signal that we could get out of them. And what we found is that we were able to get as good signals comparatively to the epidural and the subdural arrays, the ones that required this invasive surgery. But we can do it without doing the surgery, and that's the real benefit of this technology. So I'm not going to talk too much about stimulation, but obviously as an engineer we want to know what else the device can do. So we did some stimulation. We injected current through different electrodes, and we were able to find different responses depending on which electrode we used. One example shown up the top where we fed through stimulation and we were able to get a facial twitch in this particular animal. And obviously different animals had electrodes placed in different spots and they got different responses. So So we can also stimulate through that, but I just want to mention that briefly because that is not our primary goal at this stage. At this stage, we just want to record the information and use it to control prosthetic limbs or equipment. Safety is obviously going to be a big concern. What we found was that in vivo, we were able to measure the size of the vessel. We could put contrast back through where the stent was, and we could see that the vessel was still open and still patent. And you can see that in this image here. After an animal that had been implanted for 12 weeks, there was still a vessel and still blood flowing through the stent. We hadn't occluded it. And obviously, in terms of the signal strength and the quality, we were also very excited to find that after 20 weeks and after 6 months, there was no degradation in this quality of signal that we're getting. So unlike the other devices that get encapsulated in fibrotic tissue and stop working over time or stop being as effective over time, that didn't occur to ours. And one of the reasons for that was with our device in the blood vessel, it gets incorporated into the blood vessel itself. So the distance, if you will, between the electrodes and the brain is shorter. The electrodes get anchored in place. We're getting a very stable signal, and the device is functioning better over time and remaining stable for as long as we've had them implanted for. We also obviously wanted to make sure that the vessel was open, and we could do this at very different time points. We're lucky enough in Melbourne to have a nice big synchrotron that we can use just down the road. So we took some of these brains, and here's an image here. Synchrotron's very high resolution, so we had to do a large number of scans to get the brain. And you can see in these dots here, this is where the electrodes are inside the vessel itself. The images on the right here show the vessel, and you can see this black circle in the middle. That is the vessel, which is still open, even after, in this case, up to 6 months. The white dots around the side here, that's the stent and electrodes. And you can see that they're incorporated into the vessel now, which is anchoring it in place and helping us to get this good signal quality. And obviously here's underneath is histology images of the same animals and same slices. What this means is that the vessels don't occlude, and that again was one of my concerns. If we're going to put something in a vessel, are we going to block it off? What's going to happen? And obviously blocking off vessels is not a good thing. So we were also very excited to find out that in no case there was vessel occlusion, like not one animal, not one slice. And this is from the 20 animals that have been implanted for up to 6 months. We also found that vessel incorporation occurred within 2 weeks. That's the vessel accepting the device and holding it in place. And that correlates very strongly with our improvement in signal quality that we're getting. So this is a benefit to us. I mean, a lot of technologies, particularly in cardiac, they don't want the stents to get incorporated because it means they're not functioning as well. We want this to happen, and it's happening very quickly, and it's giving us really good signals. So we're very excited about it. So where do we go from here? Obviously, we've done a lot of the preclinical tests. We've demonstrated proof of concept of this technology. We know that it can record signals and meaningful signals and signals that are related to movement and intended movement. So the next stage, obviously, is to work towards a first-in-man trial, and we're on the way of doing that. We believe we're very close. We just need to do a big, thick set of paperwork for the ethics and regulatory bodies, but otherwise the testing is looking good, and we're very excited to have the opportunity to be implanting one of these in a patient group, and we really hope that this is some technology that will be able to greatly improve their quality of life and hopefully the lives of others around them as well in the not too distant future. So future applications, I always get asked a question on what else can this be used for, so I thought I'd mention this now to stop you from having to do this. And obviously if we can access the brain and access the blood vessels in the brain, there are large parts that we can access in many different regions. Epilepsy is one alternative, and we can record and monitor and potentially suppress epileptic seizures without having to perform craniotomies. Parkinson's disease and cerebral palsy treatments at the moment require neural stimulation, again using electrodes that have been punctured through the brain and through a small burr hole in the skull, and this is a way that we could use our device to treat these conditions without this invasive surgery. And obviously there's some information coming out from around the globe on using stimulation to treat post-traumatic stress disorder and depression, and this is another another option that we could pursue that is a lot safer than the existing technologies. So thank you very much for your time and patience. We've had a great time doing this work, and obviously I really look forward to hopefully coming back in a couple of years and telling you more about the patient work that we're doing, which is only just around the corner. As with all these projects, very large teams required, and I want to draw your attention to the four guys in red, Tom, Sam, Gil and Steve, who are the workhorses behind a lot of this, and the team in general. So thank you for your patience, and please, if you have any questions, I'd love to hear them. Thank you.
Thank you, Nicholas. You've done something remarkable. You've brought us ahead of time,
Very
which is
good.
great. So there's
Very
plenty
good.
of time for questions. And I have one here. First question. Can we have? Yep. Oh, you're first. Okay. Sorry, I didn't see you. My eyesight's not good.
Thanks for a very inspiring talk. I was just interested to know what your electrodes are made of.
Sure. So with most of the electrodes that you'll hear from the guys speaking after me, they're made from biocompatible materials. So there's a set that we can choose from, and ours are no different and are made from platinum.
You're excited and I'm excited. I think it's fantastic what you've done. Blood's a fairly good conductor, so have you been able to optimise the number of electrodes in the stent and their separation?
Yeah, look, that's a great question. And I think one of the reasons that our signal quality gets better over time is because the endothelialization, the tissue that grows over the electrodes within a couple of weeks, insulates each electrode from each other. So we have looked at separation and how close we can get the electrodes and how densely packed we can get these devices to get more electrodes, which might mean more degrees of freedom and more ability to control things. And yes, that is an issue, at least in the early stage, but we haven't seen that as an issue after a couple of weeks when the device is incorporated. Thank you.
Thank you for the talk. I was wondering,
Sorry.
what's the predicted lifetime of the device? I mean, the body is a very corrosive environment. Despite being platinum, I assume over time it will degrade. So,
Yes, good question. I should mention that the electrodes themselves that are recording the neural signals and neural information are made from platinum. The self-expanding scaffold, if you will, is made from nitinol, which is a nickel-titanium mix. Now, these have been implanted in cardiac work to keep vessels open for a number of years. They don't seem to be degrading. The issue with the devices in cardiac work is the tissue grows over them. Now, as I mentioned, in our case, that's a good thing. But the devices themselves aren't designed to be degraded. Now, obviously, a lot of work is being investigated of how you can have self-dissolving stents that will essentially, leave nothing but the electrodes behind, and that is something that we might look at in the future. But at least for this stage, they're very robust. Thank you.
Yeah, Mike is near. And who's next?
Hi there. Is there any chance that you'd be able to remove them at a later stage after they've incorporated into the wall?
Yeah, great question. The surgeons don't like the idea of removing them. There is a way that you can do that you can remove the tissue that's over the top. That's not their preferred method, and they're more than happy to leave them in, and indeed it's common practice to leave them in and not remove them, and particularly after 14 days it would be wiser to let them remain.
Hi, John Fraser. Congratulations, great presentation to you and your team. Follows on really here as a medic. No matter how brilliant a device, the body tends to infect it sometimes. So whilst it's great to see your early data up to 12 weeks with no thrombus, what do you do when we do DBS surgery? We see infected leads and we have to take them out. We see infected pacemakers. How are you going to get it out? Because you will have to, sometimes someone's going to get infected.
Yeah, great question. So we have been working a lot with some of the guys at the Royal Melbourne Hospital who have more expertise in this than I do. Lead infection is obviously an issue, particularly if you have a lead coming out of the body. What we're envisaging is not having any wires coming out of the body itself, obviously they'll reduce the risk, but not completely avoid it. But one of the advantages of this technology, and obviously this is the way that some of the deep brain stimulators are going at the moment as well, is to have some wireless telemetry so that there is no external, internal sort of connection. Yes, there could be issues with lead wire infections, but this is not something that clinicians are too concerned about at this stage. But
We have an expert in epilepsy here.
oh, very good, very good.
I'm not going to ask you about epilepsy, but the advantage for bilateral limb weakness, as you've illustrated, is the sagittal sinus gets both motor cortices in one go. Do you and your colleagues have any view as to sort of how small a vessel this technology is going to be applicable to? Because that will depend on accessibility to other bits of the brain. I mean, I'm not quite sure how you get to the subthalamic nucleus for deep brain stimulation through a vein. That will be quite a challenge.
Yeah, great question. So obviously there are veins of very different sizes, and as you pointed out, some of them are extremely small. The technology, the catheter technology, is getting smaller and smaller, particularly as they're using it more to use on neonates and infants. So the catheter sizes are getting better, and the ability to make electrode arrays smaller and smaller again is improving. So I do believe that it is an area we will be able to access. As I said, I'm not a interventional neuroradiologist, so whether or how tricky it is to access these using the blood vessels is not my forte, but I have been informed that it is something that we should be able to do in the future.
John Groves?
Hi, just wondering what sort of patients you'd be likely to use the device on first, somebody that requires stimulation, or whether recording is the easier way to go?
Yeah, great question. So the first patient cohort will be quadriplegic patients, and the aim would be for them to be controlling a computer cursor, 2D control, and then they'll upgrade to 3D cursor control, and following that, either an exoskeleton or a wheelchair or something like that. So in the first case, it will be purely recording, and obviously following on from that, there's stimulation applications that will be investigated as well. So one of the benefits as well of the placement of our device is that there's the motor cortex, and just next to that is the sensory cortex. So we have the opportunity to record information about what the patient wants to do, how they want to move their hand, for example, and also feed back information for how hard they've grabbed or when they've touched an object. So so hopefully we have the ability to do that as well.
For a nice presentation. Can you tell us a little bit more about the development of the implantable recording unit that presumably will send wireless signals back to a computer that's helping to control wheelchair, robotic limbs, etc.?
Sure. So there's a long-term technology that we're working on, which will have miniaturized wireless implanted on the stent directly. And while that's coming to fruition, the idea is to have a pacemaker-style box implanted in the pectoral region, and then we'll be able to send neural signals or extract the neural signals directly through the skin. So we are developing two stages of technology, and obviously one will feed onto the other, and we're hoping to get a device that has all the electronics onto the stent itself, which hopefully mitigates all the problems with having lead wires and infection like that. So.
Jim Williams?
In surface physics, in non-living systems, it's now possible to get multi-detectors at the nanometer spatial dimensions and also the nanosecond time dimensions. Has anybody gone down that path to see what could be adapted into a living system?
Not yet, but I'm sure there's future collaborations where we can get things smaller. At the moment, what we were trying to do is get as big an electrode in as possible rather than as small as possible. But yes, obviously single cell is something that has been looked at for particularly the penetrating electrodes, and if that's something that can be used to augment this device for that application, then Yeah, that sounds like a good idea.
I'd just like to draw this to a close by commenting that I heard a lecture by an anaesthetist called Emery Brown in MIT, who's using a much less invasive technique, EEG, to study brain function under anesthesia. And it will be very interesting, I think, to see the correlation between the observations you're recording and his. He's arguing that anaesthetists are not making enough use of EEG to observe proper coma states and so on. It'd be very interesting to see the correlation. Of course, one would be much less invasive than the other.
Hopefully.
Would you please join me in thanking Dr. Opie for what's been a very stimulating lecture, and I think offers great prospects for the future. Thank you very much, Nicholas.